Hi, I'm Emily Farkas from CTSNet Global, and we're here at AATS in Los Angeles, and I'm with Dr. Loretta Erhunmwunsee, who is from City of Hope in LA, and we welcome a discussion with you on what you've presented here at AATS.
That's good. Thank you so much. Well, first of all, it's a pleasure. It's very nice to have this discussion. My one presentation yesterday was around how we can create shared decision making that is basically responsible in cross-cultural encounters and situations. And I was actually as part of the ethics consortium, and it went really well. And the ultimate point was, hey, we need to create connections and we need to actually talk to our patients, listen to them, but really understand their needs and their hopes and their goals for surgery or for care. And we need to just make sure that we aren't doing all the talking, but that we're actually listening to them, and creating shared decision mechanisms that actually work for all cultures.
Sure. Well, that sounds like a good strategy for any patients, right?
Absolutely. That's exactly right.
And a good reminder for all clinicians.
That's right.
What kind of strategies, other than being sure to listen, do you normally employ to assure that?
Yeah. Well, I think for me, it is one, creating trust is one of the most important things. And I think I want to be the physician and the surgeon who, when patients come in, even if they're afraid, they leave feeling like there's someone in their corner. And that's like one of my main goals. And so I do that really by, as I mentioned, listening and understanding sort of what the thoughts they had about their diagnosis, their fears around their diagnosis, and what they really want. And then I really just sort of reiterate the fact that we're partners. I think, I am the surgeon, so I have skills and expertise in that lane, but that they are the experts for their bodies and for their lives. And so that we really got to do this thing together.
Yeah. So refreshing to hear. And what would you say if you had a colleague that wasn't representing that strategy the way you like, or you see them doing something maybe that wasn't aligned with all of the things you just mentioned?
Honestly, I think I would say simply that there's a bunch of data that shows that outcomes are better when patients really feel seen and heard by their physicians, their providers, and their surgeons, and that they have better experiences. There's a lot of data specifically, and this was presented yesterday during a talk, around African American and Black patients who really feel less seen, less heard. They feel like their encounters, that there are less sort of positive cues. There's less referrals to other providers who might be helpful as well. And so one of the things we mentioned was that these things actually contribute to the poor outcomes that we see in some of these groups. It's not, folks have higher risk of, getting a disease, for instance, lung cancer, but also these encounters that are less pleasing for these groups also contribute to those poor outcomes. So what I would say to my colleagues is, hey, let's do better. Like, it's not just, we don't have to be our best, excellent self in the ORs only. It's also in the clinic rooms and in those encounters.
That's a compelling message. And so I'm going to pick your brain a little bit about a scenario that would happen in a humanitarian global surgery setting. So when we see many different cultures and we all of those messages that you've just relayed are things that I try to think about, for instance, when I'm in Nigeria or Ghana or Nepal or another place. I've had scenarios where I try to speak to a female patient and her husband is next to her, and the answers to the questions come from him and not from her, and it's cultural for that to be the case. How would you handle something like that?
Yeah, that is so no easy answer, right?
Right.
I will tell you that at the beginning of my practice, I got something similar from certain cultures where like the child would do all the talking for their parent. So similarly, sometimes they would say, and I don't want you to give them the diagnosis. I don't want you, if they came in with a lung nodule that I was suspicious for cancer, or if there was a biopsy proven cancer, they would do all the talking, and they would say, please don't tell my parent that they have this cancer. And initially, I was sort of very adamant. Look, I cannot cut on someone or operate on someone if I don't hear from them
Sure.
and if I can't disclose what we're doing. Like I felt very, very strong about that. But since I've sort of matured, what I've realized is a couple of things. One, it's more complicated than that. Two, like even if I'm staying with that patient for an hour or 30 minutes or 40 minutes, however that encounter is, they're not, they go home with that caregiver, that husband, that son or daughter, that, and so I've got to, as best as I can, try to understand that culture and try to understand that dynamic and not be disruptive to it, right? And so the old me of I am absolutely going to tell your mom and dad about if that's changed because I realized that Loretta, you know, your 30 minutes does not equate to the tens and decades of years or whatever. And so so that's one part. It's trying to more fully understand. I do try my best still to communicate and get some dialogue from the patient.
Sure.
And I even say to that caregiver who's probably more English speaking or just more of the authoritarian, and I put it all on me. I'm the kind of doctor that really needs to connect with my patient. So can you please interpret for me, or can my interpreter please allow us to create this relationship and bond? And I put it like, I need to talk with your wife. I need to talk with your mom. So and I would love for her to talk back to me too. So can we try to do that? And many times they're like, oh, okay, yeah, mom, she wants to talk to you directly. And so I've found that allows for more of that opening of that space. But I would love to hear your thoughts too.
Well, I was just thinking I need to remember this strategy. Yeah, no, I think that's that's what you have to do is respect the situation, the context that you're in, and do what you're comfortable in, but recognize that they come from a scenario that's maybe not relatable all the time to us, but reinforcing the patient-doctor relationship in this way is really the way it should be, isn't it?
Absolutely.
And it's such a refreshing reminder. So it sounds like your strategies have evolved over time. Is there anything else that's come up recently that you've thought, I did this a little differently before and now I'm approaching it from a different angle?
Well, I think I'm a health equity researcher, and so I spend a lot of time thinking about, as a thoracic surgeon, we think about our patients and our techniques and length of stay and outcomes and complications and all of those things. But I'm really starting to integrate more the fact that what the patient's social and environmental context is into even our treatment planning and just as I assess the patient, I want to now more fully assess that part of them. We now know all of their genomic sequencing data, right, and stage and all of that. But I think it's also important to really understand, like, where do they live? Is the structure of their environment one that's conducive, or that might be a barrier to what we're trying to do for them? And how I've evolved is I've understood that many times, or sometimes at least, my surgery isn't enough, even for early stage disease. A homeless person with lung cancer who gets operated on does not just need a resection, right? A person who lives in a horribly polluted area or in an area that is very deprived doesn't just need a resection or even adjuvant or neoadjuvant therapy. Like we've got to understand that our treatments can't be impacted by the social determinants, right? And so then we have to know them. Right? We've got to measure them. We've got to understand them. We've got to speak to patients about them in a trustworthy fashion. And so that's a long-winded answer, but yeah.
I think it's beautiful and spoken so elegantly, and it's so interesting to hear your work. It's we focus so much on surgical techniques and perhaps our program volume and our metrics.
That's
and
exactly right.
Even though we all care for the patients, sometimes we lose sight of the fact about how our relationship affects them and how it affects us.
Exactly.
Right? So it's just wonderful to speak with you. I'd like to hear more from you at CTSNet in the future, and we really appreciate your time today.
Thank you so much. This is great.
Thank you.
Thank you, guys.